when we talk about men's orgasms, they talk about the point of no return, you know, the I'm going to come moment. We don't talk about that with women, but because we're physiologically the same, we also have that moment. It's like, this is it. It's going to happen. You get to that moment and then it doesn't happen.
What if the medication that's helping your mental health is changing your sex life? Today, we're talking with experts about one of the most common side effects of antidepressants, the impact of SSRIs on arousal and orgasm. Why does this happen? And most importantly, what can people actually do about it? Our guests today bring in both sides of the science. Dr. Laurie Mintz is a psychologist, certified sex therapist, and leading voice on closing the orgasm gap. She's joined by Dr. Suzette Johnson, a board-certified OBGYN who brings decades of clinical experience treating women's health from a medical perspective. Together, we break down what SSRIs are doing in the brain and body. If you love getting into the science of sexual health, this conversation is going to give you clarity, validation, and a new way to understand your body. Welcome to Sexology Lab. Each week, we speak with the most compelling minds in modern sexology to ask the questions shaping the future of desire, connection, and human wellness. Let's dive in. Hello, everyone, and welcome to the lab. Today, we're joined by Dr. Laurie Mintz and Dr. Suzette Johnson. Welcome.
Thank you. Thank you.
All right. Now, I want to know, where in the world are each of you joining us from today?
I am joining you from Gainesville.
And I'm coming to you from Chester, New Jersey.
Amazing. Now, I want to start out by hearing each of your origin stories. So if you could each give me like your 30-second origin story. How did you find your way into the sexual health space?
Well, mine is, I'll try really hard to do 30 seconds, but it's really hard. So I'll go really fast. I was a psychologist and a professor, mostly dealing with eating disorders. And then in my 30s, like many women's story, I had 2 young children, a job I wasn't very happy with, but that was causing me stress. And he'll admit, I'm not saying anything I wouldn't say in front of him, a partner who wasn't doing his share of the household and child rearing. And no surprise, poof, my sex drive was gone. And so I started looking into the literature because I knew how to do literature searches. And I found, wow, there's actually stuff I was never taught in grad school. The word sex was never uttered in grad school. Hence was born my first book, A Tired Woman's Guide to Passionate Sex. And I won't go on with the story because you asked for 30 seconds, but it's snowballed since then to the point that now I pretty much eat, live, breathe sexual health.
I love it. That is a really great origin story. Thanks, Laurie.
Sure. Thank you.
Very good, Laurie. Well, let's see. Mine's a little different. I'm a board-certified OBGYN, and I specialize in menopause and sexual health. But actually, the way I came into this sexual health profession was from my patients. I was working, seeing patients all day long in my office, seeing them for their well visits. Everything went fine, no issues. And literally, as I was walking in the door with my hand on the doorknob, they would say, Dr. Johnson, one more thing. I don't want to have sex. Dr. Johnson, one more thing. I don't have desire. I can't have an orgasm. And honestly, I wasn't trained in any of that. And I didn't even ask those questions. I didn't even know to ask women about their sex life. And so I didn't know, how am I going to treat this? So that just kind of made me stop and think and say, hey, what's going on with women? Why don't they want to have sex? And I started looking into it. I started to learn. I started to investigate. I asked questions. I went to conferences. I read books. And then I started to realize that, yeah, this is just persistent out there. Women are really having sexual issues, and it's just not one thing. And so I just made it my life's work to go into sexual health. And here I am. And I'm so happy I didn't. And if I hadn't been, I would have met Laurie, which has been like a wonderful part of my career.
I love that so much. We need more medical professionals with education in sexual health, and we need more clinicians. Like we need more therapists, psychiatrists, psychologists with more education in sexual health.
100%.
I'm really excited to dive into today's topic. So we're going to talk about why SSRIs affect orgasm. And this is an exciting topic for me because coming of age and taking SSRIs, like it was kind of like an urban myth that like it affected your sex drive and people didn't really talk about it much. Your doctor never talked about it with you at all. But now we have a lot of science behind like why this happens. I want to start at the foundation. So, what do SSRIs actually do to the brain and how does that connect to arousal and orgasm? And also, what are some examples of SSRIs? Because somebody might not recognize that term right off the bat listening to this. So let's go into it.
Sure. Well, I can start with that. So SSRIs are made out of medications that actually work in the brain to increase serotonin. And so some of those medications you might know as Prozac or Zoloft or Lexapro, or they're called sertraline, fluoxetine, escitalopram. So those medications work by increasing serotonin in the brain. And serotonin is really helpful for mood and decreasing anxiety and just kind of overall emotional regulation. But one of the other things this does is it has this inhibitory effect on the brain. And doing that, it decreases dopamine. And dopamine is our neurotransmitter that actually is for reward. It gives us motivation and those kind of things. So when it dampens, when the serotonin increases and dampens the dopamine, kind of sends an overall effect to our bodies and actually then has an effect sexually where it dampens our arousal, it dampens our excitation and actually affects orgasm. Well, I think it's important to also understand that it just doesn't, I mean, women have sex with their brain, honestly, but it doesn't stop in the brain because it has an effect on arousal too. Arousal is a neurovascular process where the brain sends these signals, which then allows things to happen in our body to increase blood flow, increase nitric oxide, those kind of things in our tissues that send those signals for engorgement and lubrication. So if the whole process isn't working, then down the line, all that goes awry.
Yeah, absolutely. So why specifically orgasm? So why does that part of the sexual response seem to be the most affected, like when you're looking at sexual health?
It's actually not the most affected, but it's the one that upsets women the most, to be honest with you. There was a study that looked at what percentage of women have SSRI-induced dysfunction in different areas. 83% had arousal problems they identified, 72 desire problems, and 42% orgasm problems. Well, actually, it's not that it is the highest percentage of problems. It's the one that bothers women the most. It's the one we hear about the most. There was a study and they asked kind of what percentage of women have problems in what area, and women could say more than one area. And 83% said they had arousal problems, 72% desire problems, and 42% orgasm problems. And I think the reason women are most upset about orgasm is because it's really the end of the experience for a lot of people. It's the pinnacle. It's what they're driving for. And also the fact that the highest percent said arousal, in my mind, also sort of has implications for orgasm, because if you're not aroused, you're not going to orgasm. Right. So I think the women in this study picked sort of the entry point of the problem, which was arousal. But without arousal, there is no orgasm.
And orgasm is really one of the most dopamine dependent parts of the sexual response. So that dampening effect certainly causes so much muting of the ability to reach that climax. And that's the struggle for women. So I think they put a lot of pressure on themselves during that process, which is, unfortunately not all there is, but that's just a learned thing. I think that's what Laurie helps her clients with in this situation.
And so then from a medical perspective, so would you say that arousal is the most common sexual side effect you're seeing in patients?
So yeah, I think the most common things I hear about are decreased desire, muted arousal, decreased sensation. They don't feel, their orgasms are delayed, they take longer, or they just can't have an orgasm. Overall, they just feel like their body isn't working the way it used to.
Neither of us work with men very much, so there's not much to add there. But one thing I like to explain to my clients who are having SSRI-induced orgasm that's like an aha moment for them is that when men have premature ejaculation, one of the treatments used is a low-dose SSRI because it delays orgasm. Yeah. And when women hear that, when I heard that, it was like, oh my God, you're giving people a medicine to delay orgasm, when they want it to be delayed, of course it's going to delay orgasm in people who don't want it delayed or muted or gone.
I love learning about this because I feel like a lot of women are out there listening who are probably like me and like they notice these changes and they just didn't know the science behind it or why it was happening.
True. So
Yes.
true.
Yeah, exactly.
And I think a lot of times when patients are started on this medication, they're not given all the side effects, specifically more of the sexual ones. I mean, I say, oh, you might have a headache, you might have some nausea, it can cause you to have a lot of yawning, those kind of things when you're starting an SSRI because, they're getting all that serotonin and very rarely they come to me and they say, oh, they didn't tell me that. They didn't tell me I was going to have problems with sex or I wasn't going to be able to have an orgasm.
Absolutely not. Thinking back on my life, what they told me, they were more concerned about like suicidal ideation. They're like, if you start having like any thoughts of suicide, like please call someone. But really, as far as like side effects go, that was it. That was all I got. They were like, read the pamphlet if you want to know more. And I'm like, okay.
And I think that's because it's not that they don't know the side effects, maybe. Doctors and psychologists are not trained to talk about sex, and they're raised in the same culture as the rest of us, so they're a little uncomfortable bringing it up to the detriment of their patients.
Some are embarrassed, some don't want to bring it up because they don't know how to talk about it. We're not trained. I mean, anecdotally, I can tell you that they did a study and they asked, just in terms of women in menopause, they asked OBGYN residents, Mayo Clinic OBGYN residents, internists and family practitioners leaving their training, how comfortable they felt taking care of women in menopause. It was only 7%. So can you imagine the percentage in sexual health? I mean, I'm going to say it's less than 1% because we don't get any of that training. And being an OBGYN, you would think, I mean, we're taking care of women and women having babies and, and all these kind of things. We deal with their genitalia all the time, but we don't talk to them about these things that are so important, such a big part of our life.
Yeah. Tell me any of the sexual side effects.
Yeah, because we give them for PMS. We give them when women start to have some depression during their pregnancy. That might be the first time they're introduced to an SSRI. And at that point in time of their life, they're not really thinking about their orgasm. They're thinking about making this baby and having a healthy pregnancy. And then they stay on it for postpartum depression because you don't want to have that risk of them having a severe depression. Yeah. And they continue on it. And then that's when they start to realize, wow, oh, I have this little baby. That's why I don't want to have sex. But really, a lot of it has to do with they're also adding this SSRI, SNRI, we should talk about too, because those are also play a role. Those medications also have the same effect. And those are the ones that kind of increase norepinephrine, but they also work with the serotonin.
And so looking at like the SSRIs and you said SNRIs.
For an example of an SNRI, Suzette, would be buspirone, right? Not buspirone, bupropion.
Wellbutrin.
So things like Effexor, Cymbalta, those are SNRIs.
Wow. Okay.
Yeah. So Wellbutrin is actually, I know for jumping ahead here, but Wellbutrin or bupropion is actually used to offset the effects of an SSRI, to kind of just level it off, because it's something that doctors will do when a woman comes in and says, hey, I don't have a desire. Well, let's add Wellbutrin to your regimen and see if we can help diminish the effects of that serotonin.
And that's for desire only, though, not for orgasm.
Some doctors do use it for orgasm when that's the complaint. Not that it really works, but that's what they know.
Oh, because it's what they know. Yeah.
Yeah.
I should have started with the SSRIs and the SNRIs because I think that we forget that they do the same thing. It's just in terms of the serotonin. And so that serotonin effect is also very prominent in the SNRIs as well. Even though norepinephrine is there, norepinephrine is like a dopamine in and of itself in some respects because it's excitatory, not inhibitory like serotonin, but it still has the same effect with orgasm and arousal.
Okay, this is a really good distinction because I think a lot of people are prescribed a brand of medication and they know it's maybe for depression or anxiety, but they're not totally sure which category it falls in or what neurologically it does. So I think it's good to make that distinction between the two.
Right, because the overall effect is serotonin decreasing dopamine. That's the overall premise of this whole thing. And they both do the same things. They're kind of same category.
And so I'm curious. So with SSRIs and other medications like that affecting arousal and orgasm, is this something that's only happening to a few people or is it far more common than what we talk about?
It is far more common than what we talk about. And I'm going to go back to those stats. for arousal, 83% of women who take SSRIs have arousal problems. And that, maybe that number of orgasm, 42% of those taking SSRIs sounded small. But when you look at how many women are taking SSRIs and you do the math, that's like more than 20 million women having sexual side effects.
Wow.
You add in menopause sexual side effects to orgasm, and if you combine those, we're talking 43 million women. Yeah. So this is like, people aren't talking about it, but they are suffering from it.
Is anyone having orgasms? Like, what's going on?
I can tell you that I am postmenopausal and on an SNRI. And thanks to working with Suzette, I am having orgasms because there are solutions to this that only a very few sexual medicine providers know, which is part of why we're so excited to be on your podcast, because we want the world to know, not just people who are sexual medicine providers and those of us privileged enough to go to one.
Yes. It's exactly why we have these conversations. There's so much that we don't know, so much that can help people. It's just a really important topic. And now, once someone starts struggling with orgasm, does anxiety or performance pressure start to layer on top of the medication effects?
So it starts with biology. I can even speak to the experience myself. Like, I was orgasmic. I started this medicine and it was gone. Just like it was a brick wall. It was physiological. I mean, every bone in my body told me, like, this is not my body anymore. It's acting different. But then, now I knew what was happening, right? And I have Suzette in my life. But for other women, especially those who weren't warned about this, who don't know what's happening, who think or who know what's happening and have been told there's nothing you can do, choose between depression and anxiety and an orgasm, then that's when the anxiety comes up. It's like, can I overcome this? Is it going to happen? Is it going to happen? Maybe it'll happen this time. And we know that being up in your head, worrying, makes you less sexually responsive and orgasmic, because you have to be fully absorbed in your body to have pleasure and orgasm. So once a woman has lost an orgasm, then there's so much layered on top of that. And then there's relationships issues too. Do you tell your partner that happened? What if they don't really buy the idea that it's the medicine? They think it's something you're doing wrong, or they're doing wrong, or they're upset about you not having an orgasm, which is going to add more pressure. So it spirals. It really spirals. It's like a stuck together bowl of spaghetti. Like, you can't take one strand out, right? You take one strand out and all this other spaghetti stuck to it.
Yeah. And so it sounds like when we're talking about SSRI related orgasm difficulty, there's a biological and a psychological component to it.
I'd say that a little differently. I'd say the biology is what's happening, but the biology causes the psychology problems to follow. Because I don't want women to think that their lost orgasm is due to their brain, the dopamine, the serotonin, but I don't want them to think it's something they have control over psychologically.
Right.
Yeah.
True. That's a good point, Laurie.
And so what does orgasm difficulty because of SSRIs actually feel like for people? So, we could talk about physically, but we could also talk about emotionally and relationally.
I can talk to this a little bit too, because as Laurie, I went through a time in my life when I had some anxiety and started on an SSRI. And because I knew about it, I was shocked that, wow, I couldn't have an orgasm. And honestly, even though I knew about it, it was still very upsetting to me, because I thought, this is what my patients are feeling. Like, you feel like you're almost there, you're ready, and then poof, it just doesn't happen. And you get frustrated. And I remember feeling like I was struggling so hard to have this orgasm that I got a really bad headache. And I thought, my gosh, is this how my life is going to be? Do I accept this going forward, or do I stop my medication? And it becomes this struggle, this inward struggle. I mean, it really just helped me understand what my patients were feeling, how awful it felt. And then, you're with your partner, think, well, I don't want them to be frustrated. So I fake my orgasm because I want my husband to feel like he's taking care of me. And he's, because that was always one of his big goals, like make sure that my wife is having a good time because that's what he wanted. And so that became a really difficult task for me. And I tried with vibrators by myself, masturbating, and it wasn't there. I just think that knowing that there was something else I could use was helpful for me because I knew I could get something topical and use that to offset the effects of the loss of orgasm. But most women don't know about it. Most doctors don't know about it.
I will add that just a little, like mine felt like when it happened, I had the same thought. That wasn't the first thing I thought in the moment, was now I know what my clients feel, but it really was an empathy building experience because it was like really happening. And it's like, that moment right before orgasm, if you're orgasmic, it's going to happen. When we talk about men's orgasms, they talk about the point of no return, the I'm going to come moment. We don't talk about that with women, but because we're physiologically the same, we also have that moment. It's like, this is it. It's going to happen. You get to that moment and then it doesn't happen.
Mm.
That's how it felt to me. And it's like, wait
Yeah.
a minute. Usually when I get to that moment, it then happens. It's like, instead, nothing.
It's like torture.
So frustrating. It's so frustrating. Yes.
Yeah.
So with all of this said, do you think people end up feeling like, okay, now I have to choose between my mental health or having a good sex life?
Yes, I think that they do feel like they have to choose, but they don't have to choose. It's just we've created this false choice, I think, between mental health and sexual health, and they don't belong together, but patients deserve both. They deserve both. The way to find that is to encourage them to speak up, but there are ways around that where you don't have to have one over the other. That's just an unhealthy thing to do.
I can even remember a client years ago who lost her orgasm, who had been very clinically depressed. And this was before I was in the sexual health field. So before I knew these different opportunities. And that's what her doctor told her. And she came to my office and she said, this is so hard because I was so depressed. I know I can't go off of these. She was suicidal. She said, so I'm going to pick my mental health, but not having a good sex life is also affecting my mental health.
And your relationship as well. So
Yeah.
they all go hand in hand.
Yeah. And I want to dive into that relational piece a little bit more because we've touched on a couple different points so far. But what happens inside relationships when one partner is experiencing this and they don't fully understand why? And even after they do understand why, what happens in the relationship?
I can't answer that with a one size fits all, right? Because every relationship is different. And it all comes down to the strength of the trust and the communication and how many myths the man is buying into and the woman's buying into. So the best case scenario is the woman says to the man, I lost my orgasm because of this SSRI, and they talk about it and they know this is a medication side effect, and then the woman seeks help. The worst case is the woman is not telling her husband because she knows he's going to get upset and blame her, blame himself, or starts faking. And then there's a million gradations in between of those situations. So it's not one size fits all, but it can get really difficult and ugly, really.
Do people talk to their doctors about this, about the sexual side effects, or do you think they're just silently dealing with it?
I think many are silently dealing with it, that they're embarrassed or assume that nothing can be done. So if I bring it up, I'm sure there's nothing that can help me because I need to stay on this medication for my mental health. But you know what it is women actually want their doctors, their healthcare providers to ask them those questions. And evidence shows that if we ask, they are relieved. There's like this immediate sense of relief, like, oh my God, they brought this up, and then they feel comfortable. So I always ask my patients, so no matter what I'm seeing them for, I'll ask them questions about their sex life and what's happening and how are they doing.
Are you curious about sexology? Do you want to further integrate sexology into your work or your life? Well, friends, then we've got something just for you. It's called the Sexology Practice Guide, and it walks you through the ways this shows up in your work, in your life, and guides you through working within your scope, incorporating intimacy and sexual health into your work without starting over. Download this short, practical guide at sexologylab.com/guide. That's sexologylab.com/guide. And while you're here, make sure to subscribe and share. And now, back to the show.
So now let's switch and talk about solutions. What can we do? There's hope. Don't worry, everyone listening. Like, this isn't a lost cause situation. All right. So if someone is experiencing this right now, what are the real options available?
So I'm going to give you one really good option. And then, of course, Suzette can get into the medical explanations. Suzette and I have an incredible resource for you that we created together with a company called My Mojo. And because Suzette and I had both experienced this and felt passionate that we wanted other women to have the solutions that we found, we created a course called Regain Your Orgasm with mymojo.com that basically does two things. It gives all of these psychological strategies that you need to regain your orgasm, like mindfulness, like getting out of your head, like using vibrators, which are empirically supported, which is why I'm wearing my vibrator earrings, because vibrators increase blood flow to the genital tissue, and orgasm is about blood flow. We also have special receptors on our genitals for orgasm. So all that psychosocial stuff, plus a clinical consultation, meaning you get to talk to an online health company, a provider, a doctor, to get a prescription for this cream that Suzette gave me that brought my orgasm back full force. And it's often called Scream Cream. We don't love the name, but that's what it's known as. And I will turn it over to Suzette because she has been prescribing this to women for 30 years.
Probably not as long as 30 years because it took me a number of years when I started out as a new doctor to discover this. And honestly, I don't even know where I heard about it, but I thought, these women are having so much difficulty. Let me give it a try. It's a compounded medication. It's not FDA approved, but a lot of things we use for women are not FDA approved. For instance, there's no FDA approved testosterone for women, but we use an FDA approved testosterone that men use to give to women. But compounded medication in some respects are very, very helpful. And back in the day, we would try things like sildenafil. We would give oral sildenafil for women who were having issues with orgasm or arousal to see if that helped. But what this cream is just a combination of sildenafil and other ingredients that go to the tissue to improve vasodilation, that improve nitric oxide, which brings all this stuff, this good blood flow to the tissue. And women need that blood flow for things just like men do. And that's how they have an erection. So to engorge the tissue, to make it more supple and more available for, specifically, is a lot of it is for penetration as well, because it brings lubrication. These vasodilators do is they improve the tissue. And when you bring that blood flow, you bring all that to the vulva and the clitoris, you can then improve the orgasm response. That's one way that I think is so important because it's non-systemic. It's not like you have to take a pill. You don't have to worry about all these other potential systemic side effects. So yeah, could there be some side effects with local irritation when you're using any kind of topical cream or something? Those kind of things can happen. But the side effects are so minimal to none that it's a great option for women.
And as a user of this, I can tell you the first time I put it on, I know because I'm a sex therapist what orgasm is. It's blood flow to the internal clitoris mostly. That's where most of the erectile tissue is. There's some on the hood and glands, but not as much as inside. And it's blood flow. It's an erection, right? And then the blood is released by rhythmic contractions of the pelvic floor. Well, I never really felt the blood flow before, right? I never felt the lady boner, if you will. I put this cream on and was like, oh my goodness, my clitoris is swelling. Like I'm getting a lady boner. And it felt great. It felt amazing. Yeah. Just putting it on, let alone the huge orgasm that came after.
I have had a lot of good success with it. Does it work for every woman? No, it doesn't. But a lot of times there are other things that are going on too, besides, that they just are using. Maybe they would be better off if they saw a sex therapist, saw a Laurie Mintz to find out if that really the only reason why they're not attained. Because there's, the stress that's involved and all the other things that go along with it. Just using this topical cream, if you're not dealing with the whole picture, you may not get the benefit of using just this cream.
It's kind of interesting to me that I've been thinking about, I don't know if I've even said this to you, Suzette. SSRIs themselves work alone, but they work better in combination with stress reduction strategies, mindfulness, exercise, talking to someone. So, and in fact, a lot of times people will try those psychological things and they don't kick in. They don't work as well till you also add the medicine. So it's the bio plus the psychosocial for the depression and the anxiety that start this. And the same is true for this cream, right? You can just use the cream and it's great, but really combining it with the vibrator, the mindfulness, which is why Suzette and I didn't want to just start a company selling the cream alone. We wanted to bundle it with the psychosocial strategies, teach women that, and then they can keep using the cream, but it's also they have the cream on top of the skills that they get along the way too.
Yeah. And I love that. It's so important because getting that educational piece is so important along with like the physical cream that can help like from a medical perspective. So it's about putting this all together for people.
I think too, we're seeing that a lot of these sites now are starting and just selling you the cream, selling and not really giving you the information you need to understand why you're using the cream or what it's going to be doing for you. And that's what's the difference that we bring with Mojo is that we are giving them all that bundle, if you will, of, treating the whole person and not just that little area of our body.
And now I want to know, are there any adjustments that people can make? Could they change their medication? Could they change the timing or the dosing or anything that could help from a medical standpoint?
Yeah, I mean, first and foremost is if this is certainly an issue is to follow up with your provider who's prescribed the medication, talk to them about what's going on. Because certainly, yes, it could be a dose issue that maybe the dose should be decreased. It could be a timing of the medication when you're taking it. It could be that maybe you just add something like a bupropion or give something like a Buspar. Just giving additional medication can help. And then there are also, like we said, the topical treatments that can go along with that. But certainly there are other ways. It's not one size fits all. There are different ways to adjust medication and look at different medication because women don't have one and give up the other. There are ways around this and it's treatable.
Yeah. It's like, let's stack the deck in every woman's favor. So all the things that you could possibly do, let's share it. Let's talk about it.
Even there was a Mayo Clinic paper that looked at all the evidence of different things that women could do with SSRI-induced dysfunction. It came out like a long time ago before this cream, and they didn't even know about the cream, but they talked about exercise before sexual activity because it gets blood flow going. They talked about vibrators. They talked about scheduling activity and taking your pill after the scheduled sexual activity. And all of this information is also in the course because we didn't want women to just get the cream. We wanted them to get all of the evidence-based information.
Now, you just mentioned a couple, but are there other ways that people can reconnect with their body and reconnect with pleasure, like while they're on SSRIs?
Masturbation, which actually, let's not use that word because I just learned that the origin of the word is to defile oneself.
Oh, I didn't know that. Learning new things.
Eliminate that from our vocabulary. Self-pleasure, because self-pleasure is so great for two reasons. One, there's no one else there to worry about. No one else distracting you. And you can change the pattern or the type of stimulation immediately. You have a direct input from your genitals to your brain, which during partner sex, you don't have. Which, side note, men get that during intercourse. Men during thrusting get direct feedback from the penis to the brain and they can adjust this, that, the other. There is no partnered sex act where women get to do that except touching oneself with their hand or vibrator during partnered sex. And I know this is a different topic, but I feel so important about telling women this. That's why that's a scientifically supported technique. And women think, oh, that's less sex. And I want women to know, no, it's more sexually empowered and intimate to touch yourself during partnered sex. And it's the only way you can get immediate sensory feedback from your genitals to your brain. Because when you're with a partner, by the time you say to the right, the moment has passed.
It's so true. It's so true.
Very well said. Now, at the end of the day, is orgasm still possible for most people on SSRIs, or does the goal need to shift?
I think it is possible for most with the help of someone like Suzette, who knows all these medicines and others that can be given. However, as Suzette said, it doesn't work for everyone. And there are some people who have a more serious form of post-SSRI dysfunction. There was a New York Times article on it. And this is people who, like, their whole sensation is gone. It lasts for years and they are so affected. And I might not be correct, but if I recall correct from that New York Times article, a lot of that happens to people who it was started in adolescence when we were still developing sexually.
Yeah.
No, not everyone, but a lot of people. And in fact, I have a very dear friend who has that. She started an SSRI in her late childhood. And now her orgasms, her genitals are so muted, she can hardly feel them. I'm not telling anything she wouldn't tell. Actually, her picture was in the New York Times article. And she's a dear friend of mine. I told her about this cream that Suzette prescribes and how to find a doctor to prescribe it. And she got it prescribed. And did it bring her orgasm back? No, but she said she actually felt sensation in her genitals. People, I think there's a solution, and keep looking, keep talking to a doctor like Suzette, a sexual medicine physician, which you can find at the International Society for the Study of Women's Health website, or the International Sexual Medicine Society, ISSM. But for some, no, I think they have to accept the loss that sex isn't going to include that for them. And sex therapists always give the advice, like, don't pursue an orgasm. Pleasure is the measure. Emily Nagoski says that. It's her famous line, pleasure is the measure. And I got to disagree. If pleasure was the only measure, then the top second most common concern women would bring to sexual health providers wouldn't be missing orgasm. Women want to orgasm.
Yeah.
And they have every right to pursue orgasms, behaviorally, medically, and psychologically.
I did say that we're not really trained to look at the clitoris. My goal when I was teaching residents was to teach them how to do that. And some women do have some issues with their clitoris that could impact their ability to orgasm. And they could have, adhesions. They could have a skin condition that can mute their orgasm. So it's really important to not just think that there's a fix for it with a medication or a topical. It really involves having somebody take a close look at your clitoris and your vulva to make sure that everything is the way it should be.
I got referred a client who'd been to 6 sex therapists and had seen 6 sex therapists. All gave her the same techniques for orgasm, and she wasn't orgasming. And we sex therapists have lacked training of when is it medical, how to tell.
Yeah.
So I said to her, I'm not taking your money. If you've been to 6 sex therapists and have they done this, yes, I said, you need a good doctor. You don't need me. And in fact, she went to see someone who found out, I don't remember the exact details, but she had some nerve issues going into her clitoris. I don't know what that would be, Suzette, but they're like her nerves were not functioning very well in that area. SSRIs aren't the only thing that can cause missing orgasms or muted orgasm.
And I think that's why the cross-disciplinary collaboration is so, so important in this field.
And if you don't get an answer, you go find somebody else and ask them the same question, because there is somebody out there that can help you.
All right. Well, I would love to wrap things up with a lightning round. So I'll read the question and then you can each give me your short answer. I feel like it probably is a smaller sample set who really can't orgasm. Like we just talked about, there might be medical reasons and things like that. So if somebody who can't orgasm still wants to have good sex, what does good sex look like when orgasm isn't the main focus?
Complete immersion in pleasure.
All right, Suzette, you're like, agree.
Agree. Oh, yeah. I agree. Yes.
All right. Now, my next question is pleasure optional in healthcare?
No. Pleasure is part of quality of life, and quality of life is part of healthcare. So it goes together.
what she said.
All right, next question. What's one sexual health book you would recommend to our audience? Yes, I love it.
The
Okay.
Coming Clitoris by Dr. Laurie Mintz. It's really been used a lot. So this is the one.
I love it. Laurie, tell us like a
Yay.
little bit. So if somebody's like becoming clitorate, what is it about? Like, can you give us a little synopsis?
I can. It's half cultural analysis about why women aren't orgasming so women stop feeling broken, and the rest really clear self-help to empower women to orgasm.
I love it. Yeah, definitely would recommend. Laurie, is that your recommendation as well, or do you have another book?
I'm going to go ahead and say, I didn't spend a year writing it to not recommend it, but I will say in a year, about a year from June, I'll have another book to recommend called Know and Tell, A Woman's Guide to Self-Exploration and Self-Expression, also by Dr. Laurie Mintz. I'm going to just plug myself here.
Plug it. Yes. Yay. I'm so excited. I'm so excited you're working on this. I can't wait to read it.
Thank you.
All right. Last lightning round question. Who is a guest you would love to see on the Sexology Lab podcast?
I think you should have Silva Neves in. Has he already?
There's an episode. We recorded it. It's in the works, so it's going to be out pretty soon.
Okay, amazing. Well, then I'll have to give another one. I absolutely love Ian Kerner. And Ian wrote She Comes First. He's an oral sex how-to manual. And in fact, I credit Ian. People don't know this. I did not come up with the title Becoming Clitorate. The word clitoracy and clitorate was Ian's word. It's in the back cover of She Comes First. And that word is his creation. And I called Ian and I said, I love this word. Can I use it for a book title? And he generously said, of course you can, Laurie, because the more clitorate people in the world, the better.
Yes, I
That's
love that.
perfect.
Yeah.
That's perfect.
Just a couple closing questions. So this one goes to each of you. What's one message you would send to anyone who feels like they've lost a part of their sexuality because of medication?
Seek help. You can get it. Likely you can get it back. Do not give up. Just
Right.
because your doctor doesn't know about it doesn't mean that you can't seek help. Find a doctor who does. And that's why we created a public course. So you don't even have to find a doctor. You can just access the course.
I would say you're not broken. You do not have to choose between your sexual health and your mental health. Most things are treatable, and just talk about it, ask about it, but just know that you're not broken.
I love it. Such great advice. And we are also on a mission with our sponsor, Sexual Health Alliance, to provide high quality sexual education to professionals in the field like doctors, nurses, other medical professionals, and of course, sex therapists who didn't get that education in graduate school. Now, this question is just for Dr. Laurie Mintz. You have presented with our sponsor, Sexual Health Alliance. Can you share a little bit about what that experience was like for you?
It was lovely. Thanks to you, Michelle. You made it seamless and easy from beginning to end. It was also my first actual Sexual Health Alliance conference, and I was presenting, so I was a little nervous, right? Like I'm a stranger here presenting, and everybody was so warm and so welcoming. And I just felt so welcomed and included. It was just lovely. And I recommend your conferences to everyone.
Oh, thank you so much. All right. Well, Dr. Suzette Johnson and Dr. Laurie Mintz, thank you so much for joining us in the lab today.
Thank you
So
for
welcome.
having us.
Yeah, thank you for inviting me. I really, truly enjoyed this. It was awesome.
Thank you. All right. Bye, everyone.
Bye.
Bye. Thanks for having me.
Don't forget to subscribe on YouTube, Spotify, Apple, or wherever you listen. Links are in the description below.